The 2012 Sir Godfrey Hounsfield lecture will be delivered by Professor Stuart Taylor, Professor of Medical Imaging at University College, London. Stuart has an international reputation of excellence in research in gastrointestinal radiology. He is a leading researcher in the fields of CT colonography and the role of functional MRI in the assessment of gastrointestinal inflammation and neoplasia. He has published extensively and has authored or co-authored 110 papers, 18 book chapters, and 1 book. He was the Röntgen Professor of the Royal College of Radiologists in 2009, and he is currently the chair of the Gastrointestinal Committee for the European Society of Radiology, and is playing a leading role in GI radiology in Europe. He is the recipient of numerous prizes, awards, and research grants. I now invite Professor Stuart Taylor to deliver the 2012 Sir Godfrey Hounsfield lecture, CT Colonography for Colonic Neoplasia. Stuart.
Thank you very much. Thank you very much for that kind introduction, and to the BIL for asking me to give this lecture. So I think I've got roughly about 45 minutes, I might go a bit fast, to talk about CT colonography for colorectal neoplasia. What I've done is divided into 2 halves. First half probably more interesting than the second possibly, so I should have swapped them, but also the history of CT colonography is quite interesting, and particularly if you compare how it's been disseminated between the US and the UK, and how successful it's been over here compared to over there, and why that may be. And the second half, I will just outline some of the new updates to the technique, just to get you up to speed of what we should be doing in clinical practice. So what is CT colonography? Well, as you all know, it's a helical CT of the cleansed distended colon. It comes under various names: virtual colonoscopy, pneumocolons, colograms, but we should be using the term CT colonography as the official term. So as you know, you can look at the images in 2D or 3D. I won't get anybody to point out where the abnormality is on this scan, but if you look in the mid-sigmoid, you may see something coming up. Or you can do an endoluminal fly-through, which I think most would agree is much more easy to see the abnormality on the endoluminal fly-through. So we can look at the images in these 2 different ways. So how good is CT? So I'm going to start at the end and sort of work backwards. So I'm starting with the headline figures for the diagnostic forms of CT. If you do want to look at that for yourself and you go to PubMed and do some clinical query, it's going to take you a long time because there's a lot of articles on CT colonography. It's been a very popular subject in the literature. But fortunately for us, the best way of sort of combining those data is to do a meta-analysis, and quite a few authors have done that over the years, which basically combines the data and gives you an overall headline figure. And if we do that, this is the sort of data we get. So these are the latest meta-analysis on the right. As you go from left to right, the number of patients increases because more studies have been done. So if you just remember, for the large 1 centimetre plus polyps, sensitivity between 80 and 90%, towards the 90 in good hands. And for the smaller intermediate 6 to 9 millimetre polyp, it's about 70%. And we'll come on to talk about polyps a little bit later, whether they're important or not. For colorectal cancer, clearly our symptomatic work in the UK is very important. And quite recently, meta-analysis has been done for colorectal cancer. And again, reassuringly, CT's got a very high diagnostic performance, 96% sensitivity. So in fact, comparable to conventional colonoscopy. So therefore, we should all be using CTC, and is that the case? Well, as I said in the introduction, if you go to the UK, and I think that probably is the case now, it's accepted by the radiological, gastroenterological and surgical communities, and it's pretty widely implemented now in the NHS. If you compare this with the USA, it's not fully accepted by the communities even now in 2012. It's got very patchy implementation. So I think it's actually quite interesting to look at why it's so different in 2 different healthcare systems. And it's all about backing the right horse. You have to pick the horse. So if you're going to win the Grand National, you have to know which horse you're going to back. So it's choosing the right thing. And another, you can't get away from this, is how funding follows the patient, or how does it go from the patient into your wallet. And of course in the NHS we get paid whatever we do, so we do 1,000 bare minimas or 1,000 CT colonographies, it doesn't really matter, we'll get our paycheck at the end of the month. Whereas in the USA it's completely different, you get reimbursed per procedure done. So if your procedure, such as CT colonography, is not reimbursed by insurance companies, you don't get paid for doing it, therefore your motivation for doing it is much less. So that's one of another big drivers to why the differences exist. And so as early as 2005, NICE, which governs everything we do in our day-to-day lives, actually says CT colonography was fine for symptomatic patients, and it even got it in for asymptomatic screening patients. That's back in 2005, whereas in the USA, as late as 2009, CT colonography is still not reimbursed by the major insurance companies, so therefore radiologists don't get paid for doing CT colonography. So much as the example of the turf battles that go on when you have a fee per item system, it's sort of unheard of in the NHS with gastroenterologists who want to come and do our CT colonographies for us. But in the US, where you get paid for doing them, then that is what happens. So in centres which do reimburse, certain states do it, the gastroenterologists are trying to do CT colonography, thinking it's a natural extension of endoscopy and should be their domain rather than us as radiologists. So that sort of summarised why I think CT is different in the two different healthcare systems. But it's quite useful to go back and look at the UK work as to why we picked the target lesion as being cancer symptomatic patient, and just acknowledged a lot of work that was done in the UK and Europe to reach that goal. So I'll go back to the adenocarcinoma sequence which we've all just talked about. We look at symptomatic patients, so you have to just one step back. What is a symptomatic patient? Well, it's somebody who may have symptoms because they've got colorectal cancer, that's pretty self-evident. So it's basically not a screening patient. It's not even a patient with a positive FOBT. It's somebody who may have a colorectal cancer and they've got symptoms. And whatever branch of radiology you work in, you will be aware of 2-week wait guidelines that make you do your scans quicker if the patient may have cancer. And colorectal cancer has got its own set of 2-week wait guidelines for symptomatic patients. So the causes are clearly colon cancer. A large polyp may cause symptoms because it can bleed, but it's not small polyps. So our target, the 6 to 9 millimetre polyps don't matter in the symptomatic patients because they're not going to cause the symptoms. So we don't have to worry about them if you don't see them. And of course we can see other causes, benign disease, extracolonic disease. But if I go back to these 2-week wait symptoms, as in nearly every cancer 2-week wait pathway, the vast majority of patients don't have cancer when they go through this 2-week pathway. In fact, in colon, we get 2-week guidelines. Less than 10% of patients have cancer, so 90% don't. So clearly, you want a test that's not going to harm patients, that's quick and easy. So here spoke to us this morning, and he's older than he looks, because back in 1996 he was reporting a technical performance paper of CT colonography. So in fact this was back in 1995. So where in the early days of CT colonography, the focus in the UK was on detecting colorectal cancer, not on detecting polyps. And they very pertinently said a bare minimum can be difficult and distressing for frail elderly patients, and CT may be the alternative for these patient groups, completely different from the well asymptomatic patient cohorts that the US were focusing on. And back in those days there were 4 slice scanners, hopefully none of those are around too much now, but we were taking 2 or 3 breath holes to scan the patient, so it's quite a prolonged procedure. And again, they sort of projected how CTC may be used, so a very good test in those with a high clinical suspicion of chronic neoplasia, or someone where you found a cancer and you want to stage the patient, and you can spare the patient having bare minima or indeed colonoscopy. So again, this is a very good sample back in 1995, this group was predicting how we'd use CT colonography. And again, very early on, back in the sort of mid to late 90s, the same group were publishing pathological correlation with colorectal tumours. Again, cancer was the focus for the test. If you compare that with what's coming out at the same time in American literature, These are all very good groups from the US who we've worked with in the past. So Beth McFarland, Amy Har and Adrian Beckman, all doing good CT colonography work, but they're looking at polyps, how well they can see polyps in the colon. Their attention was much more on these smaller lesions, which the endoscopists of course see very well. In 1999 was an important year for CT colonography, and there was a landmark paper in the New England Journal of Medicine from Helen Fenton, who's an Irish radiologist who went over to the States to do a fellowship and stayed. She's now working back in Ireland, and she published a 99 patient series, and CTC did very well, found all the cancers, most of the large polyps, a lot of the small polyps, and this is a real impetus to CT colonography both in Europe and in the States, because a lot of attention was generated by this paper. But again, if you go back the same sort of time point, 2000, the same time this paper, at UCH, they'd done over 400 CT colonographers. It had been introduced in clinical practice very early on. And you can tell I was a registrar at that level because they spelled my name wrong, and it doesn't matter. But the experience was there even before these landmark papers. Again, the UK was a bit ahead of the game. And again, I was fortunate to do an MD at that time at St Mark's with Steve Halligan, and it was clear from his focus, or did he tell me what to do, that the focus should be on symptomatic patients. So that's where we did our work. We did those people with rectal bleeding. We looked at the 2-week wait of patients. Could you use CT colonography for that? Just to show this technique would work well. So we were trying to kill the bare minimum. We weren't trying to compete with endoscopy like the Americans. We were trying to get rid of the bare minimum. And another important feature, of course, there's no point replacing a test if patients don't like the new test that you're going to replace it with. So we did look at the acceptance of CT, and it's important that patients find a good test. And we did back-to-back CT colonography and bare minimums in the same patient, and just asked them which one they found best. And it was very clear they all hated bare minima. No matter how well you do it, it's not a pleasant test. CTC, they were much more satisfied, interested, less frightened, felt less helpless, less uncomfortable. And all the patients who expressed a preference said they preferred CT over bare minima. So we had a mandate from the patients perspective as well to start pushing this technique. And at the same time, sort of sounding the death knell for the bare minima, there was data coming out of the States, in fact, showing that bare minima wasn't a particularly good test. Again, in screening populations, but importantly for the large polyps, it was missing nearly 50% of large polyps. So again, not good news for the bare minima. And about this time, we were also looking into, well, why is bare minima performance so bad? Is it the technique, or is it the person looking at the bare minima? This study, I think we took 20 bare minima sets around the UK, big X-ray film packets, to various centres in the UK, and showed them these 20 bare minimas and asked them to report what they found. Within the 20 bare minima cases, there were two cancers. And this is what was missed by the people looking at those around the UK in NHS practice. It's not what they saw, this is what they missed. So 90% of consultant radiologists missed at least one of the cancers on the bare minima. 6% of trainees and 6% of people who classify themselves as experts. So clear evidence that the interpretive skills of bare minima were getting less amongst radiologists. And the dissemination of CT was very piecemeal in the early 2000s. A survey at that time said a third of centres were using CTC. A lot of people weren't, but quite a few people were starting to use it in the practice. And this came to the attention of the Department of Health, because they quite rightly don't want a new technique to be disseminated piecemeal among the NHS, because standards aren't there. If you do a new test badly, then the new test can get a bad name. It's not taken up properly. So the Department of Health was noticing what was going on in the CT literature, and they asked for a study of CT colonography. And again, in symptomatic patients, not interested in screening, it's symptomatic patients. And this was the SIGAR-1 study. And so I'm going to present the results of that, because I suggested that it's all about backing the right horse, and did we back the right horse in the SIGAR study? Well, again, it was led by my colleague Steve Halligan and Wendy Atkin then at St Mark's. And it was a multi-centre trial, UK-based trial, the largest GI trial in the world that's ever been done was in the UK, and this was it. And it was led through the British Society of GI Radiology, or BUSCAR. You're probably a member of your specialist societies, attached to the Moore College of Radiologists. Well, the GI one is the Buscar. Really, why was it called CIGAR? Because in the days it started, that group actually called itself CIGAR rather than Buscar. And a whole host of radiologists from many centres around the UK took part in that trial. So it's a real achievement of UK radiology to come up with the data they did from this study. And what it was, well, the patients with symptoms of possible colorectal cancer went to their gastroenterologist or surgeon in outpatients. They were seen. If the clinician would normally do a bare minima, then they would send them for the bare minima. But at that stage, they'd be randomised between bare minima and CT colonography. If the clinician would normally request a colonoscopy, then they'd go for their colonoscopy, but at that stage, they were randomised between that and CT. So really, it's two parallel trials. One comparing CT with colonoscopy and one comparing bare minima with CTC. And there are a lot of patients, nearly 4,000 patients through the bare minima arm of this trial. It's a large numbers, randomised study. And as I mentioned, the endpoint was something important to the patient, a cancer or a large polyp, nothing to do with small diminutive polyps. It's a per patient basis. So what were the results? Well, remember, it's a randomised trial. If both tests were performing equally between bare minima and CTC, this percentage should be the same. You should find the same number of cancers, the same number of large polyps. It's a randomised study. Patients should be equally represented in each group. So the pick-up rate for bare minima was 5.6% of patients had one of these endpoints, whereas for CTC it was significantly higher. It may not look like a big difference, but that's nearly a third more cancers or large polyps found at CTC. A significant difference. We followed the patients up for at least 24 months. It's now much longer in this study. CTC wasn't perfect. It did miss tumours. No test is perfect, but it was half the rate of the bare minima. So I think our take-home message: CTC finds more cancers and large polyps than bare minima as half the miss rate. So really, in clinical practice in NHS now, we shouldn't be using bare minima. We should be moving over to CT colonography. I mentioned the colonoscopy arm, about the results of that. Well, more patients had pathology in colonoscopy. When a clinician sees a patient and they really think there's something going on with them, they tend to refer for colonoscopy rather than bare minima, as I'm sure you know if you're in clinical practice. But again, if the two tests are acting the same, this number should be the same, and it was about the same between the two tests. No statistical difference between colonoscopy and CTC for finding cancers or large polyps. So I think we conclude there is no difference, and again, CTC really can be used interchangeably with colonoscopy for older symptomatic patients. So in the UK, it's a mainstream test, many symptomatic patients. It will replace the bare minima. It should be replacing it now, and in 10 years' time, bare minima will probably be all but gone. So we did back the right horse, I think, by choosing the endpoint, the target lesions that we did. I will mention the poor old Americans, see where they are now. So as I mentioned, they went for the screening scenario. It didn't get funded in 2009. That's under review now, and they're hopeful that it will get reimbursed. Something that reflects a trend of declining interest. There was an international congress held in Boston every year since 1998, specifically on CT colonography, virtual colonoscopy. By 2010, that had actually stopped. There's a lack of delegates going. So completely contrasting to how CTC is taken up in the UK. But there is some hope for them. All the presidents are screened for colorectal cancer. It's a good thing to do for them. And George Bush had colonoscopy, but Barack Obama had CT colonography, and that's something that the radiologists have really picked up on. So maybe there is hope for them yet. Okay, so that's the first sort of historical part. So I've got a few minutes left, I think, just to update us a little bit on the technical issues of CTC. So when I've told you we should be all be doing it now, not bare minimas. So the technique we use is quite important. So I will just mention a few pertinent things. I showed you these meta-analysis. What I didn't mention at the time, behind these headline quite good results, there's a lot of heterogeneity in the literature. So if you look at these individual studies making up those headline polyp detection rate, some people are doing very well, getting 90-100% sensitivity for large polyps. A lot of people aren't doing very well, getting half that, 50% sensitivity for a large 1 centimetre polyp. So a lot of people doing well, but also a lot of people not doing so well. which clearly when you're trying to introduce a robust, usable test, that's quite alarming for the healthcare policymakers. A study that did pretty badly, a US-led study by gastroenterologists in fact, CTC had 59% sensitivity for large polyps compared to 98% for colonoscopy. So that's the comparison there we're interested in the America. Hidden behind that was showing the bare minimum was even worse, but they didn't really pick up on that. They focused on this poor performance compared to colonoscopy. But even so, I think most of us agree that's not particularly good performance for CT colonography. Another gastroenterology-led study, there's a pattern here, led by gastroenterologists tend not to do so well. They have 55% sensitivity for large polyps. Radiology-led studies, Perry Picard's very famous in CT colonography circles. He's done many of the major trials of CT colonography in the States and screened populations. Again, it was screened populations, but they're big numbers, very high sensitivity, 94% for these large polyps. And again, American, similar to the CIGAR study, they did their own study, but it was in screening patients, not symptomatic, but again, high sensitivity for large polyps. So you've got to ask yourself, why is it so different? Why is it 55% in one study and 90% in another study? Well, like anything, there's lots of reasons. Is it technology and software? Is it as simple as bowel preparation? Is it down to individual readers? There's only certain people should be reading these scans. Is it how they read them? All these reasons are perfectly feasible, and they probably still exist in the reasons behind the differences. So if we just quickly go through what you do, you just have to do CTC right. It's not an easy test that you can just do off the shelf. You have to focus a little bit how you're doing it and how you interpret it. So what are the important issues? Well, CT parameters, I guess, are quite important. So back when I was doing my MD, I remember getting a collecting specimen for somebody with FAP, lots of polyps, getting this specimen, tying off the end, putting a tube through the ileocecal valve and blowing up with air, and scanning it about 50 times on a CT scanner. This is what you've got to do to get a paper in radiology. And what we did, we looked at all these polyps, we changed all the parameters, the collimation, the pitch, the MA, to work out what was the best parameters you had to do to see these polyps. So that was useful when we had 4-slice scanners, but in reality now, most of us have moved on hopefully to multi-slice, and those sort of issues are less important. I just picked one of the meta-analysis which does some quite useful summaries, and they found that if you use a reconstruction thinner than 3 millimeters, you do better than if you use thicker than 3 millimeters. It kind of makes sense, which you do thin reconstructions. So a typical multi-slice protocol would be your collimation slight thickness less than 3 millimeters, really it's going to be 1.52 millimeters on most scanner, but make sure you keep less than 3, don't go above that. Stick to normal KVPs of 120, you don't have to change that, and do turn on your dose modulation. You don't need to have high MAs to look at the inside of the colon, because the contrast between the gas and the polyps and cancers is very high. So you don't need high MAs to look at the colonic portion of the CT colonography. So colonic preparation is very important. It's a bit tedious and it's not particularly glamorous, but if you don't prepare your patients right, then you won't do very well when you come to report them. For example, if you use too much fluid, a very wet prep like the endoscopists use, you can drown the colon out, so you can miss quite large lesions. The endoscopists can suck that fluid out when they're doing endoscopy through the scope, but of course we can't do that, and you can really compromise yourself by using the wrong type of bowel prep. And again, the early literature in the early 2000s was all about what kind of bowel prep do we use, and we looked at Citromag and P-Class and found P-Class work well. And the dogma until probably about 3 or 4 years ago was just use a dry prep. So whatever you use for bare minima, use it for CT colonography, and that's what most people did. But I've converted since then, and they've asked me 3 years ago, that's what I would have said is state of the art. But now I've converted to using fecal tagging, so I've changed my opinion, which is good, I guess. And I think we should be using fecal tagging in all our patients. And tagging is adding all contrast medium to the diet before the examination, so anything that's left in the colon is tagged white, so you can see it very easily. And it's a very good way of reducing laxatives, something the endoscopists can't do. So again, potential advantage of CT. So you give some oral barium or gastrografin probably, or some ionated contrast. The liquid in the colon turns white, so you can see it very easily. As I say, you can halve or even eliminate laxatives by doing that, which the endoscopists can't do. And you can see the polyps submerged in the tag fluid, so you get a diagnostic advantage. And clearly you're not going to call this a false positive polyp because it's very bright and highly tagged. This is tagged fecal residue. And again, go back to the meta-analysis data. What does it show? Well, if you use tagging, your sensitivity is much higher than if you don't use tagging. So I would advocate everyone uses fecal tagging in their protocols, and there's no real excuse not to use tagging now. So that's a change in the last few years. So the state-of-the-art preparation for CT colonography in your symptomatic but relatively fit patient is to use a full bowel preparation, whatever you normally use, Picolax, magnesium citrate, whatever you do, it doesn't really matter, and then add an iodinated contrast agent as the oral fecal tagging. Barium is optional. I wouldn't recommend using it, just adds to cost and complexity. Using iodinated contrast alone is enough. So an example preparation, this is from Picard, but you can use Picolax or citronide, whatever bowel prep you want, doesn't matter. He adds barium, I don't think you need to do that, but the big thing is adding some gastrografin or omnipeg or any sort of iodinated contrast to the preparation regime before. We usually do that, but we find sending out the contrast in the post is very difficult. Our pharmacy is going to charge us £15 a patient to package the gastrografin and send it out to them, and our radiology managers got a bit stressed by that. So we don't do that. So we've compromised, and we bring patients in 2 hours early. We give them the gastrografin while they're waiting. They've had their full bowel preparation the day before the Picolax, and we get them in 2 hours early, give them gastrografin, and probably 9 times out of 10, in that 2 hours, the gastrografin whips through the small bowel, fills the colon, gives you a very nicely tagged colon. Patients don't like waiting there for 2 hours. They must have done questionnaires, and they don't like it, but we haven't really got a choice until we sort out our pharmacy. Another big thing for making a massive CT colonography, if you don't distend the bowels that collapse. And again, a lot of the early work in the UK was quite boring things, but quite important things. You don't have to use a thick rectal catheter, one of those big bare minimum balloon catheters. A thin tube is fine. Do give Buscopan because it gives you much better distension. So give that routinely in all your patients. And scan patients supine and prone in all patients because it moves the gas around. And again, state-of-the-art technique now is to use automated CO2 insufflation. We shouldn't really be using hand insufflation. We shouldn't be using air to inflate the colon. Carbon dioxide is much more friendly to the patient because it gets absorbed. They don't get cramping pain. And the insufflation devices are safer. You can monitor the volume and the pressure, and you get better clinical results. So again, we should be moving away from manual insufflation into automated insufflation. Another important issue is training. We've known for a long time, like any technique, be it MR small bowel, be it MR the shoulder, whatever, CT angiography, the more you do, the better you get. This is a paper from very early on that showed that this group, in their first 20 patients, had a very poor performance. By the time they got to their last 20 cases in this 100 series, they were doing much better. So as you do more, you get better. It's self-evident. And this has been shown by the ESCAR group that if you're expert in CT colonography, you tend to do better than if you've been trained but haven't done that many examinations. There's a wide variation in performance. So some trained radiologists and radiographers do actually better than so-called experienced people. So you'll find, like anything in radiology, you're good at some things, you're not good at others. And you might find you're good at CT colonography or you're not so good. It's just down to your individual skills. And again, we sort of mirrored that bare minima study where we took bare minimas around the UK. We took 15 data sets, CT colonography data sets with large cancers and polyps, hoping that CTC would be more robust than bare minima, and UK radiologists doing it in their practice would be good at it. But unfortunately that wasn't the case. Of these 15 centres doing CTC in their clinical practice, on that 15 data set test cases, half of them were missing cancers and large polyps from CT colonography. A lot of people were doing well, but some people weren't. So we can't assume that CT colonography is an easier test in total than bare minima, because we do have to train ourselves to do it properly, and there's a large potential for making errors. And again, the more cases you've done, the better you are. So therefore, that's why CT colonography, there's definitely been an industry in hands-on workshops, and the European Society have done lots of hands-on workshops. You want to fancy a trip to a nice European city, this is quite a good way of getting your training. There's also UK ones in, I think, Leeds, St Mark's as well. But a lot of radiologists have gone through these training workshops, and basically you can sit down and do your 50 cases in a controlled environment and get yourself up the learning curve. I will briefly mention computer-aided detection. It puts a little mark on the polyp to tell you where that polyp is. So clearly that's going to hopefully help us decide where the abnormalities are. And these standalone CADs now, very high sensitivity. They're about 95% sensitivity for the larger polyps. So from a technical point of view, they do work very well. If you use CAD, you'll increase your sensitivity for larger polyps by about 7%. So I think that's quite a good argument if you want to invest in your next CT upgrade. If you're trying to get a CAD product attached to your CT colonography software, the vendors might throw it in for you to make them buy their CT from them, or you might try and get in your business case for purchasing CT software some money for a CAD, because it does definitely improve your sensitivity. Trouble is, it won't replace training. You can't just do CT colonography with CAD and expect to be at that 90% level, because CAD can point things out for you, but if you don't know what you're looking at, then clearly it's not going to help. So you do have to go through that training, unfortunately. Patient safety, very important. A few surveys a few years ago, but again the headline figures are correct. When you consent your patient, we should be telling them about perforation rate, because you can perforate with CT colonography. And a good figure to remember is about 0.03%, so 3 in 1,000. It's probably about half the rate of the colonoscopy, so it's safe in colonoscopy, but it's not immune to perforation. The good news for CTC is that the vast majority of these patients are asymptomatic, or they come to no harm whatsoever. They'll be watched overnight, or they'll even be picked up after they've gone home. You ring them up, they're perfectly fine. So the outcome of a CT colonography perforation is pretty benign, compared obviously to a bare minimum perforation with brain peritonitis, where the outcome is much worse. So we do perforate, but thankfully the outcomes are quite good. And the things you want to avoid, I've mentioned the balloon catheters. Don't use these big balloon catheters. Manual air insufflation, you don't know what pressure you're generating. You're pumping a balloon blindly, you've got no idea what intracolonic pressure you're generating. If there's an obstructing tumour, you could be happily blowing at the rectum against an obstruction and perforating that patient. And you need to be trained in what you're doing. I just pick out this one here for the patient factors. We tend to wait about 4 weeks after a deep colonic biopsy before doing CT colonography, because there is a potential to perforate if you do same-day colonography and they've done a deep biopsy in the tumour. If they do superficial biopsies, then we would do same-day CT colonography. For heart valves, there's evidence that you can do CT colonography safely, so perhaps there's an alternative to endoscopy with these metallic heart valve. And the valve preparation, whatever you use, should be prescribed. You can't get away with just ticking a box in your radiology request form saying give PCLAX. If you don't know the patient, you don't know their history, then you're in breach of these guidelines. So we've in fact changed our request now at UCH that the person requesting CT colonography has to tick what they actually prescribe in terms of valve prep, and we use that word. So they prescribe PCLAX, or they prescribe magnesium citrate. So the onus is on them, the patient in front of them, to describe the valve preparation appropriate to that particular patient. It's not good practice for you, us as radiologists, just to tick the box without knowing what the patient is like medically. And all this is boiled down to good patient information about all the things that I've talked about. And finally, important issues. Again, the UK has been ahead of the game on this in leading standards. Europe has done well. We published a European consensus. All these things I've talked about, valve preparation, distension, training, etc., all in these consensus guidelines. There's a new one coming out, which is in European Radiology this year, hopefully. But also in the UK, we've been very proactive in this. A lot of centres have been involved in this document which came out in Clinical Radiology a couple of years ago, setting standards. And this is a very good reference document. If you're setting up a service for the first time, or you really want to just have a check on what the service you're offering now, I would recommend you go and read this, because it goes through everything. It goes through what you should be doing in terms of protocols for patient safety, in terms of how you implement and interpret CTC, in terms of training, who should do CTC, all the things that I've sort of touched on now are very well explained in that document. So finally, the indications, when should we do it? Well, incomplete colonoscopy is a good indication. If they come to you in the morning and you've got time, after adding 30 mils of gastrografin, they'll have a wet endoscopic prep, so the fluid will be a lot in the colon. If you've got time, add gastrografin 2 hours before and wait before you do your same-day CTC to tag that fluid. But if you're like us, they come to you at about 5:05 on a Friday afternoon for that request, then ultimately we'll do it without fecal tagging. But if you have got time, do tag them. Symptomatic patients, I've made the point out very clearly that we should be doing that. CT is the first-line test in symptomatic patients. FOBC positives, but only if they're unsuitable for colonoscopy. And again, cancer screening guidelines now exist for use of imaging, and that's basically talking about CT colonography in FOBT positive patients who can't have colonoscopy. In terms of screening, people in the US still advocate for heavily screening in. With a good service and well-trained teams and good radiologists, then I think it is probably going to be a valid screening test, but it's not going to be a mass population screening test in the UK. Imagine the number of CT scanners, radiologists, radiographers to screen 1 million patients. We haven't got the infrastructure to do screening CTC. So it will be basically patient choice. I guess the private sector will do screening CTC because they've got less constraints than they use, but not as a national screening test, probably for many, many years, if at all. Don't use it for patients with strong family histories. You know, if they're looking for subtle flat polyps, send them for colonoscopy. Don't pretend we can find everything with CTC, because we can't. Give them the right test, which is colonoscopy. And don't use first line in FOBT positives. Half of them are going to have a cancer or a large polyp. There's no point doing an intermediate test. Go straight to the gold standard for that, which is colonoscopy. Inflammatory bowel disease, not good for looking for subtle mucosal lesions. There's risk of perforation if there's acute inflammation. So in summary, CTC has evolved from the first-line whole colon test over the last 10 to 15 years. The European and UK focus has been a symptomatic patient, and that's definitely accelerated dissemination. And I've tried to point out how the UK multidisciplinary teamwork has been pivotal in that development. And high-quality technique is important. So technique, training, safety information, evidence guidelines exist to use them. And my forward look for the next few years, we'll get rid of bowel preparation, we'll turn to non-laxative protocols. We'll all be using COUNT in the next few years. And I think it will start to roll out as a screening test, but perhaps in centres, in countries we don't have a national government funded screening programme, but in more ad hoc systems. Thank you.